technique. The two biggest failure points you can have with a consumer device is requiring compliance on a consistent basis, or on an irregular basis. It's even worse. And then technique. A good example of that is ear thermometry. You know, the thermoscan ear thermometer takes your temperature via your tympanic membrane. But how intuitive is it for you to reach across and pull this ear up to put an ear thermometer in that ear to straighten the ear canal so you could get to the tympanic membrane? It's a big problem, and that's one of the things you have to really think through, is that experience with the consumer has to be intuitive. Otherwise, as a consumer device, the cost of the media to reach them. Imagine when I worked with Gillette. Gillette owned 70% of the worldwide dry and shaving market. And by the addition of one blade to the Mach 3, 8 years ago now? 10 years ago now? They had to spend $500 million more in the U.S. in media spend just to tell you why one additional blade was important to you and that you're going to pay a 20% premium. So imagine today, those of us out there that don't even know what hematocrit is and what the purpose of hematocrit is, and you're going to get a device to measure your hematocrit. It's a big challenge there. So the compliance issue and the technique issue drives that education issue.
Fantastic.
So I love what Darrel said about that, the thermometer, and how it has to be completely intuitive for the user. Because what we believe at Proteus is you have to practice human-centered design from the very beginning when you're creating a healthcare product. And that actually hasn't been done a lot, because there's a bit of a disconnect between a lot of the processes that you use in human-centered design, which is about rapid iteration and testing things out and then changing them. So there's a disconnect between that and regulatory pathways, where you basically have to have exactly what you're regulating done and fixed 2 years in advance. And so at Proteus, we've developed a set of techniques that allow us to practice human-centered design within the medical space. And we have it laid out and documented, and we practice it all the time. So all of our efforts go through 3 stages. First, we do ethnography, and we spend a tremendous amount of time out in the field with our users to really understand what they need and what makes them tick. And then from there, once we start having product concepts, we do what we call DSIMs, for design simulations. And so, those are products that are completely inert. We don't have to have any regulatory oversight or any sort of clinical trial framework to do these DSIMs. And every idea we have goes through this DSIM, where we find clever ways to test our concepts in the field and get them in people's hands without actually getting them in people's hands. And then the third step is what we've called clue studies, for clinical user experience iteration study. And so that's actually the framework of a clinical study. So people are using real product because this is on a clinical pathway. But the point of this clue study is not to have data at the end that our product works or is efficacious. The point of this clue study is to release iterations during the course of the study. So it's a very different approach to a clinical trial. But what it does is it allows us to figure out what really engages our users and really get product in their hands, which is something you see in the consumer world all the time, but not so much in the healthcare world.
I think for Healthsense, the main thing that we've seen is the development of the engagement tools, because now you have this remote monitoring technology that can tell you an awful lot about what someone's doing on a daily basis or what their vital signs are. And to get them to accept this technology and not be afraid of it, I think it's very important for the formal and informal caregivers to be thinking about, how do we make the people comfortable with the technology, and how do we get them accepting it as part of their part of keeping them independent. So we developed something that we've coined the name Beyond Bingo, which is essentially a kind of a user experience for bringing in the older adults and a mixture of, typically in this setting, younger college folks and teachers and nurses, and just letting them experiment with the different kinds of technology, whether it's Skype or whether it's Facebook or whether it's some sort of Google Health Vault or whatever you pick, but letting them use it and really reaching out and finding what's their passion. And then once you find what that passion is, that's the way they begin to learn to use the computer and begin to accept technology. What not to do is start with their first computer experience being filling out their advanced directive. That's not fun and a good way to learn how to use the mouse. So really find what's their passion, get them using it, get them accepting it, and it really changes a lot of the perceptions, and then make sure people understand, as part of the engagement process, how this technology is helping them accomplish their goals of independence.
We have to work sort of closely with amputee organisations. We have to work very closely with distributors. We almost have like a tier system of people that we have to work and educate. As much as us getting the information of our product out to the amputee population and the general public, is that the perception of a compliant hand, in this case, is that people suddenly think they've got their own hand back again and they'd be able to do the most complex of things, you know, play a guitar, play the piano, crazy things, which obviously we still have a prosthetic device which is operated, and the signals are used from the patient itself. It doesn't have a mind of its own. So from our point of view, we set out a range of educational programs. We use a lot of webinars nowadays. Again, as Brian was saying, using Skype a lot in the situations of engaging as many, sometimes the patients direct, but mainly the clinicians.
Very good. Thank you. You know, when you look at the challenges in healthcare specifically today, or especially today, I would imagine one of the top of mind items is costs. And so when you think of digital health, how do you see technology being used to reduce costs in health today?
Do you want to start?
Oh.
Brian?
I think for our perspective, anything that's done with digital health is going to have to drive toward a total cost reduction in the healthcare delivery. We can't continue to layer additional costs on the system. So, I think a mission that we all share is how to reduce cost and how to improve quality of care. And that's, I think, something that we have to test every one of the technologies that we put out into the market. For Healthsense, it's about slowing that progression through the care continuum. And if you can use technology to keep somebody at one level lower care or one level more independent, I mean, the difference between independent living and skilled is $6,000 or $7,000 a month. The difference between assisted living and memory care is maybe $3,000 a month, and it's a huge quality of life change. If you go from assisted living, you're in a setting that you may have been in for several years and you're very comfortable. If you transition into memory care, that's a locked ward, and that's giving up a lot of freedoms and a lot of your friends. So we're very proud that you can use this technology to keep somebody in a setting where they're more comfortable and keeping them safe.
I think in terms of the care continuum, I think we look at it in kind of a roller coaster view. You're healthy, your health degrades, your disease progresses, and you have two choices of where to spend your money. A reactive health disease progression area that we are in today, or look over here on the health side. Look at the obesity world. I mean, I think the claim is there's $142 billion spent directly on care of obesity or obesity-related diseases, but there's $68 billion spent over here on diets, fast meal replacement plans, counseling, education. So there's two pools of money to look at in terms of, follow the money in terms of an opportunity. And I think this area over here is opportunistic, but it's a lot of dollars to reach a lot of people. Here, it's more clinical. And so there are different challenges, and the benefits have to be related to each one of them. Here, you're going to have to appeal to an individual and the cost out of their pocket, where over here, you're going to have a clinical approach, as Brian's alluding to, is how are they going to spend the money to prevent that disease from progressing. And I think that putting both of those on the table when you're looking at the problem you're trying to solve is probably the best approach of looking at it in terms of the cost savings.
So the reason the pharmaceutical industry is so big is because drugs work, but they work if you take them. And so, our goal is to help create systems that allow people to self-manage their health more effectively, so that they, if they take the small cost of taking their drug, that reduces the large cost of having acute events and hospitalizations. And so that's our hope for reducing costs.
Our goal is a lot more straightforward. And to supply devices into the prosthetic market, we have to fit in with already pre-existing L codes, reimbursement codes that have already been set